Hey, Andrew Van Lint here, and I'm at ANZAHPE 2019 conference in Canberra in the Australian Capital Territory. Welcome to my Airbnb, which is a lovely place, only 5 minutes walk from the convention centre. Here to share some thoughts on the first couple of days of ANZAHPE and my overly dressed nature is because I've just come back from the excellent conference dinner, which was hosted at the Canberra Arboretum. I think that's how it's said. Great band, great company, pretty good food. Firstly, what is ANZAHPE? So ANZAHPE is the Australian and New Zealand Association for Health Professional Educators. So it's basically the closest thing we have to a college type structure that can provide support and a degree of recognition for those in associate fellowship or fellowship for clinical educators around Australia and New Zealand. And probably one of the highlights of the whole organisation is this yearly conference. I first went to ANZAHPE without knowing it in 2015 when I went to Ottawa, which is a biennial assessment in health education conference, named because it started in Ottawa, but since moved around the globe. And that was in Perth, and they partnered with ANZAHPE at the time. It was a really great conference, and I still talk about some of the things that I learnt there in terms of workshops and some of the connections that I built with students and colleagues on a monthly basis, really. And then 2 years ago, I was fortunate enough to be a part of the organising committee for ANZAHPE 2017. 2017? Yeah, in Adelaide. Really great conference, convened by Julie Ash, a wonderful person I've learned a lot from, and it was great to build some connections there. Exams done last year, great to be free of that, and great to be back at ANZAHPE this year in Canberra. Let me share some thoughts. So I came a very early flight on Monday, the 6:15 direct flight from Adelaide. First thing I did was I attended some of the pre-conference workshops. So the first one was, the theme that I attended was interactive learning. The first session was hosted by University of New South Wales, I think it was, with Graham Harton and his team, and they talked about interprofessional education. It was great just with a group of 12 of us talking about how we can make things more interactive and how we can cross a lot of the disciplines. So I took some really good thoughts from that, and it was really good to meet some people who are working in a similar kind of space. Then we had probably what I would say is the highlight of that particular workshop was with Lauren Sanders and her team from the University of Melbourne, where they talked about a lot of interactive activities that can be done in a large group format by breaking up into smaller groups, either with or without facilitators. We started by doing a pyramid activity. So we were asked individually to write down thoughts on what we felt helped make a really good interactive teaching event or session. And then we met with one other person, and then we were asked to kind of bring it down to just 3 by combining our 2 together. And then we met with another couple, and then between the 4 of us, we distilled it down to 3. And then we put ours up on the wall and compared it to the other groups. And it was really interesting that we came to very similar themes that were around that. And if you're interested, the themes that we distilled ours down to in terms of our 4 were participant involvement, time management and structure. So valuing that we need to be there at the start till the finish. We need to start on time, leave on time, and we have to have a good structure and the timing that goes with that through the teaching session, and an enabling environment. So it's a safe and supported learning environment, but it also includes the physical environment that we're in and the technology that's utilised there. So I could definitely relate to that in my own teaching. They also looked at different feedback models. One that I hadn't heard before is the AERO, so AERO. It was effective, so gut feeling, how did you feel about the session? Effective, so what went well? Reflective, in terms of what could be improved, and then objective, and that's where the observer or the assessor provides their feedback. So not that dissimilar from the positive critique method, which I'm a big advocate of myself. Lastly, we had a session also from University of Melbourne. I think her name was Sandra Petty, and she talked about something they do in their first week of the University of Melbourne course, which it's called Ormond Hospital, I think it was, and that's really about exposing first year medical students who come from a variety of backgrounds, it's a postgraduate course, to a simulated environment with actors of a patient journey in a simulated hospital, and just a lot of the reflective elements and things that really even stayed with some of those students throughout the course. So that was really novel, and it's great to hear they've been doing that for some time. They were able to show us some videos of actual events. A lot of it is based on maybe a mixture of positive experiences as well as some negative experiences that are witnessed in terms of patient interactions, or even student doctor to nurse and others relationships and encounters in the hospital. So really powerful stuff. Day 2, we had one of our keynote speakers, Renee Stahlmeier, who came from Maastricht University. If you're new to the medical education scholar area, I don't know what it is, but the Dutch have got it. I've got some Dutch ancestry, so I'm like, yeah, cool. Maybe I could get some of that genetically. But Maastricht University, well known globally for its medical education research. I wasn't surprised to have a guest from there. So she's done her PhD, and then her topic was it takes a village, and the focus of that was about the healthcare team's role in a resident's workplace learning. I really enjoyed her talk and talking about that the team that a resident works with, and with that the multidisciplinary nature. So nurses and physios, as well as the doctor team and other allied health and even social workers and even administrative people that help develop or help facilitate the workplace learning. And that can be stuff that I'm very passionate about, like systems navigation. Like, how do you actually get things done? This person needs an echo. Someone needs to tell you how to get that echo. And that's when you first learn very early on in your career. And how do you access, restricted medications or investigations that are hard to get by? How do you order a consult? How do you get things done really smoothly? And the learning as well that goes around that is delivered by doctors and pharmacists and others. And I really agree with that. It takes a village to train a resident, and the village is in the hospital. I hope that we can do that back more, and I think we already do that back where I'm from. I went on to a session that was by Katrina Anderson, who's from the ANU Medical School. She was teaching about, it was a workshop on teaching and mentorship skills. So she outlined a program which I think is fantastic, which is, I think they call it a associate fellowship or something like that to their higher education academy. And the way that perhaps title holders, for example, in our Adelaide context, or clinical educators can acquire that, which seems really good on paper, is they have to complete 10 modules, which is a 12-hour face-to-face course that covers a number of different topics. It was great because she said that they really focused on taking the medical part out and focusing on the relationships that they have, and about perhaps what some people call the soft skills, so not actually the content as such, but talking about how they reflect on their own practice and how they communicate with their students and residents and how they support their training. Was really some really good stuff. And the interesting insight that came out of that was, even though many people seem to be drawn by the carrot of this association with the Higher Education Academy, many of them didn't actually go on to request the qualification when they did the course. The course itself was actually rewarding enough, and that had everyone from an intern up to, and even some students, up to senior consultants. And in fact, it was the registrars and residents attending in the first kind of phase of this course rollout, and them coming back and talking excitedly about the content and then applying it, that really inspired a lot more senior clinicians to then be involved. So I love that idea, because we're already thinking back home about how do we engage our title holders, how do we support them? How do we invest in them very intentionally to train them up in the things that they're already doing, the informal teaching, as well as the formal roles that many of them have with students and trainees on the ward. So love that idea. Had a really great chat to my dean about that and where that might take us. She talked about some of the main themes or principles of the way that they teach educators is the use of narrative or stories, having visual aids or visual prompts that help convey certain messages, using key words and really highlighting those keywords as they come up through the conversations, and really recognizing that wisdom is in the room. Certainly kind of a theme of the conference that we're at here is that wherever, even to junior to senior educator, you're going to have wisdom and great experience. That part of the point of having some of these training programs is to get that to come out and for people to learn from each other's experience and each other's wisdom. I really agree with that. There was a concept that she covered, which was, what's your philosophy of teaching? Apparently this is something that a lot of organisations will ask prospective employees to talk about, give a statement, what's your philosophy of teaching? And we did an activity where we thought about 3 words that encapsulated our philosophy of teaching, and then we either drew a picture or found a picture on the internet that helped convey that. For me, my philosophy of teaching would be journey, experiential, safe and supported. And the picture that I chose was a caravan of camels in the desert. And the idea is that the educator is the leader of the caravan. They've taken this route before. They know the destination they're going to, and they can help those coming along on the journey make sense of the journey and the experiences that they have, both expected and unexpected, along that journey, both providing the protection and support for the caravan on their journey. I wonder what your philosophy of teaching would be, what kind of picture you might create or find to represent that. Dangerous Ideas in Medicine. Rebecca Szabo and her team, which I think was also LKey and Anne. 3 points that came out of that. The first one was about allowing a degree of disruption or being disruptive to traditional ways of doing things that will actually, I almost feel like it's a bit of complexity and chaos theory that's in there. A shout out to Koshila Kumar, who did a session on that. I wasn't able to attend. But big take home for me from there was about how Rebecca, as a kind of growing clinical educator, but obs and gynae background clinician, was really building very powerful communities of practice and networking using Twitter and other means of electronic and social media connectiveness. That really inspired me to look at how else I could connect with my community of practice as educators and clinicians around Australia, New Zealand and beyond. So that's been great. I really enjoyed having further chats with her about that space. Secondly, we heard about the CMO or Career Medical Officer pathway. That there's really, and this is something that I think gets discussed a lot at the pre-vocational medical education and training forum that happens. So I think if people are interested in this area, go there. It's a really hot topic. And this is really talking about people as they finish their internship and they're not getting into a training program. Where are they sitting in terms of training? Who is taking responsibility for supervising and supporting and facilitating and protecting those trainees and providing them opportunities? Because in a lot of health systems, they are just kind of, their rotations are changed willy-nilly, and they're the people that are filling the gaps for everyone else. So I think she was really advocating that we should be intentionally thinking about that and providing more training opportunities for these trainees, and thinking about, for those that actually don't end up doing training, are we appropriately recognising their skill? Are we providing them with support and training that recognises their unique development as well? And with the really tsunami of medical students that are becoming junior doctors, that space as a pre-vocational trainee has really expanded hugely in the last 5 to 10 years. I've certainly witnessed that myself in my own networks, but it sounds like that even in the eastern states, it's happened even more. Training positions are increased, but they're not increased in the same proportion as the number of graduates that are coming through. So I think that's a really topical area. Lastly, there was a really good talk about closing the gap between academics and clinicians. So we do actually have many people that straddle that gap. I would count myself amongst them, as a growing and very early career academic and educator, but also reasonably early career clinician as well. There are some people that only do the academic side. They're really well steeped in medical education scholarship, that not all educators are, and definitely very few clinicians are. And there are plenty of people who are clinicians who do a bit of teaching, and there's often a big disconnect between the organisations like universities and them, and there's a big disconnect in terms of translating medical education research into real practice, as much as, and definitely more delayed than clinical research evidence is as well. So I think the takeaway message of that was, we need to build meaningful connections. There needs to be respect on both sides of that bit of that chasm, and we need to improve lines of communication so we can understand and support one another better. Wellbeing, a number of different presentations there. I learnt that a lot of medical students don't eat breakfast. I learnt that a number of medical students don't sleep very well, particularly before exams. Up to 18% of them take over-the-counter sleeping products to help them before exams. Didn't measure how many use it at other times. There was a really good concept that was from some younger presenters on having wellbeing days. So they introduced, I think at Sydney University, the idea that you can basically have like a mental health day that is, you don't have to do a 6 certificate or anything. You can just take the day to rest and recuperate and reflect, and if there's been something serious that's gone on in your life, just taking time out to calm your mind and emotions, and so that you can kind of keep going. It really sparked some really interesting debate around, how do we compare that to sick days? Is that translatable into the clinical environment later? So are we actually setting people up with unrealistic expectations, or actually is this a really good thing that we're allowing them to have? They also had a system where it was flagged that if someone was taking perhaps too many in total during a year, or too frequently in a short space of time, that would initiate a support process from the faculty. I certainly like that kind of idea in helping identify and intervene early with students who are in distress. So some really great ideas there.